Well, IBD is a disease that is from the intestine, and it comes from an inappropriate reaction of your immune system, which consists mostly of your white blood cells, to your intestine. And this causes inflammation, this causes changes in the bowel movements, causes diarrhea, pain, abdominal pain, and also fatigue can be one of the symptoms. Misconceptions in IBD are mainly the fact that the disease is a chronic disease, and this is something that is not really seen often as a real disease. It's a hidden disease. It's a chronic disease that impacts on the long-term patient's life. And this is an important misconception, and this is also why patients have difficulties to explain what exactly is happening with their body and with their intestine, and why they are feeling sometimes more fatigued or having pain, because you can't see it from the outside what really is happening with those patients. The impact on the patient's life of IBD is that there is a change in the bowel movements. So this can be really impact also on the social life of the patient. It can make that patient are not daring to go somewhere because of they have diarrhea and they have to go to the toilet often. Other things that impacts also is that, of course, because of the pain that they may experience, that they also are sleeping less well, they're more fatigued, and that they're also not feeling well along the day. And this is something that is like we mentioned before, is not seen that from the outside, but it's an important impact on the patient's life.
The biggest effect of IBD in my life is that I'm more tired. When I was not having IBD, it was 100%, and now on good days it's 60%. The way it affects my life is that I lost my job. We really wanted to have a bigger family, but we didn't because of the lack of energy. Also social. There are a lot of moments that we are going to an appointment and the day I have to cancel it. So I think my world is getting a little bit smaller. I think that's the way it's the biggest impact. Yeah. And it took a long time to get the right medication again, and it felt like I was living in the waiting room of my own life, and there was a 2-year-old girl walking around, and I wasn't able to be the mother I would like to be. I wasn't able to the partner I would like to be, daughter, sister, friend. And through that time, we decided not to go for a second child. And this period, I think, was the most difficult time in my life. Yes.
Over the last year, we see that there is still an increase in the number of diagnoses in IBD. We call that the incidence, so more and more patients are diagnosed with IBD. And because of that, and because of the fact that it is a chronic disease, also what we call the prevalence, so the number of patients, the total number of patients with IBD is also increasing. And we saw that over the last 20, 30 years in the Western countries, the industrialized countries, but now we see also those trends coming in the newly industrialized countries, like, for example, India or other very large population countries have also an important increase, which increases enormously the burden of IBD on the healthcare over time, and we probably will see that over the coming 20 to 30 years there will be a steadily increase in IBD all over the world, and it's something that we initially saw in the Western countries, but now all over the world it will become. The real reason why there's an increase is not so clear. It's also because we don't know exactly what the cause of IBD is. We know that there's an inappropriate reaction of the immune system against external factors. This might be food factors, environmental factors, pollution eventually, but we do not exactly know why this is happening. Well, indeed, over the last years there are plenty of medications coming to the market, what is a good thing for the patients, of course, but on the other hand, once you have more choices, it's difficult to choose what treatment is best for what patients. So this is really a concept that we are working on nowadays, to choose really the medication that fits best to a certain patient. From a patient perspective, of course, but also from a medical perspective, because not all medications work in each patient. And the thing is that we do not know at this moment what medication works best for one specific patient. And this is one of the downsides. Of course, it's always better that we have more treatments than only one, but knowing what we should give at a specific patient would be even better. It's an enormous challenge to find the right treatment for a patient, because at this moment there are no predictive biomarkers, which means that there's no way that we can say upfront what treatment will help for that patient. It's like playing darts, what we do nowadays. So we throw the arrow and we see where it lands, and we see whether it works or not. So if we could have a predictive biomarker, so a test that says upfront, this is the best medication for that patient, that would be very helpful. Well, an important consequence of the fact that we do not know exactly what treatment fits best for the patient is of course that we give treatments to patients that are not the right, or probably not the exactly right treatment for that patient. So the chance that the patient reacts or the disease is under control with that medication is lower. And also with that, there is also a pharmacoeconomic aspect. So it costs the society more if you give drugs, very expensive drug, to patients where you don't know upfront whether it will work or not. So this makes, of course, that you spend money to a treatment while you know that there's a big chance that it's not an effective treatment for that patient. And you lose money, but you lose also time, because you expose the patient to a treatment with also side effects. And of course, while the disease is not under control, there's accumulating damage to the bowel also in that patient. So there are different side effects from not knowing what to give to a patient. We try to explain to patients that from our perspective, that medication would be probably the best, but we also have to be honest to the patient that we do not know upfront. And this uncertainty is really a hurdle for us, but also of course for the patients, because you have to test and retest to see after a certain moment whether it works. And if it doesn't work, you have to start a new treatment, again with the same story, not knowing what the effect of that drug in that specific patient will be.
From the moment I was diagnosed, it took, I think, 3 or 4 years to get the right treatment. I was hoping it would work. I was hoping for the good times and the light in my life, and to be feeling alive again. But it didn't happen. So it felt, it was a dark period in my life, yes. I wasn't able to work. I was sitting at home. My life was making my child of 2 at the time ready for daycare. I was going to bed again, and when she came back, we were having dinner and I was bringing her to bed, and that was my life. I wasn't able to do anything more. So it was a huge impact. Yeah, it has a huge impact, yes. There was a moment I was thinking, there isn't a treatment, and I think I was feeling a little bit depressed at the moment. Well, not I think, I was depressed at that moment, and I was asking for a stoma, because it's difficult to watch a life and to have a child and to live in a world, what's going on, and you can't do anything. You can't join, you can't participate. Yeah, that's really difficult. Yeah.
Well, over the last decades, we changed our way we manage it. That's because we have more treatments, of course, but we also changed our follow-up of patients. We now know that really being on top of it, certainly in the beginning of the treatment, is very important. That we have to adapt our treatment or change the dose of the treatments from the beginning when we see there's no response. That's called the treat to target or the tight control of the disease, where we have sequential tests that can be blood tests, stool tests, or just looking at the symptoms of the patient, and we adapt our treatment based on that. And we know that if we closely follow it, closely adapt to change our treatment based on that evaluation, that we get better results over time. In the past, we followed patients just based on symptoms, but symptoms are not always reflecting exactly what the degree of inflammation is in the bowel, because symptoms are variable, and it's not because patient is symptom-free that also the disease is under control. So the real target is to really control the disease, and this is always a combination of the symptoms of the patient, but also the biomarkers, so the test that we do, blood test, stool test, or other tests that we do, and the combination of that is really providing us a better insight into the degree of inflammation, and if we try to control the inflammation maximally, then we have better outcomes over time. The treat-to-target approach is important because studies have shown that this is really a game changer. There was one study, which was the CALM study, where patients were given identical treatments, but one group was treated just based on symptoms and the other group was based on symptoms and biomarkers. And it showed that patients treated with treatment that was based on symptoms and biomarker had way better outcomes compared to the other group, where both patients had the same treatment. So the treatment was adapted each time in the more strict group, and that leads to better outcomes over time and better control of the disease. Multiple studies have shown that patients that achieve mucosal healing, complete normalization of the intestine, that those patients have less surgery, less complications, less hospitalizations, less need for change of treatment, less need for corticosteroids. So that's an important factor. Objective monitoring is very important because it says us, in combination with the symptoms of the patient, most of what the degree of inflammation is. And the symptoms are important for us, but also for the patient, of course, because this is really impacting their daily life. But it's not always reflecting exactly what the degree of inflammation is. And so by combining symptom control and also control of objective markers, helps us to really control the disease. And this helps us also to have better long-term outcomes in patients with IBD. Well, in the follow-up of IBD, there are two important biomarkers that we use. The one is CRP, which stands for seroreactive protein. That's a blood test, and which is a sign of inflammation in the body. But there can be several causes of an increase in the CRP. For example, if you have an infection, you have also an important increase in the CRP. But in the situation of inflammatory bowel disease, it's also a very good marker of systemic inflammation. So the ongoing inflammation in the bowel, you can measure that in the blood. And the other test is fecal calprotectin. Fecal calprotectin is a test that we do in stool sample, where we again measure a marker of inflammation. Fecal calprotectin comes from white blood cells that come into the lumen of the bowel, and then you can measure those parts of the white blood cells in the stools. And the degree of inflammation again correlates with the degree of the biomarker. So the higher your fecal calprotectin is, the higher also the inflammation is in the bowel. We use fecal calprotectin and CRP very often because it's quite easy test. The blood test is even more easier than the stool test because the patient has to bring a stool sample for this. What we mainly do nowadays is that we see or follow a patient in the outpatient clinic, that we perform those tests twice or up to 4 times a year to follow the evolution over time. And this gives us an insight in how the degree of inflammation is. It's very important also that we have a sample at start of a new treatment, that we know where we start with, and that we can see how the evolution goes over time, that we have a sort of reference sample at the start. So CRP and fecal calprotectin are very general biomarkers. So this just shows you the degree of inflammation. It doesn't mean that these values indicate what treatment you should give to the patient. It's just showing there is inflammation. But of course, inflammation, the background of inflammation is very different from patient to patient. So for that, we need predictive biomarkers, and this means that you need a test that tells you what treatment will help for that patient. So overall information about the inflammation and degree inflammation comes from CRP and fecal calprotectin, but it doesn't say what treatment you should give to a patient. It just says you have to give a treatment. The most of information we have comes from studies that gives you information about the whole population, but this in fact doesn't say anything about one specific patient that sits in front of you. And this is why we absolutely need those predictive biomarkers that really tells us specifically for that patient really a tailored treatment for that patient.
So this new personalized approach with predictive biomarkers is gonna act in a proactive way. So we select the right drug for the right patients based on a profile that we hope we can quickly get from a blood sample, and from the reading of the sample from a DNA, so a genetic perspectives, more precisely from an epigenetic perspective. We're going to stratify the patient according to the epigenomic signature, and we are going to identify which the best drug for that patient is. So this is something that oncologists have known for a long time, and I believe that as they did in the oncology, we can achieve that level of precision in the next years. I believe this is revolutionary because you can really personalize your treatment based on what your genes say, how do they express themselves from an epigenetic perspective. So this is going to be revolutionary and completely aligned with what precision medicine and holistic medicine mean. So this is expected to change the IBD care, because we are not gonna select the drug based on our expectations or on our clinical practice, but we are gonna also integrate the specific profiling of that patient in our therapeutic algorithm. METHYLOMIC is a huge project, including several work packages, all contributing to a new precision medicine approach, where all projects are working on the identification of a profile biomarker for our patients. And more practically, some patients are gonna be the good candidates for a patient profiling signature, and those are gonna receive treatment based on what their genes say, and this is gonna be controlled with another group receiving the drugs based on our current experience. So there is much hope in this sense, and we are gonna see how this huge project is gonna work. But I'm optimistic that this is the way to go.